Hello, everyone. Welcome to our October Journal Club. This is Vestibular First topic of the month, Mal de Debarquement. And we have with us our very special guest who are very, very, very excited to have, Dr. Carrie Hops. More initials than I can even try to say in the mouthful. And she's going to kind of self-introduce a little bit more.
Hi, thank you so much for having me. So I'm currently the program director of the Army Baylor University Physical Therapy program down in San Antonio, Texas. I have always been an Army physical therapist. I started my career at Walter Reed during a time where a lot of our patients had blast injuries, and while they had limb loss and other trauma, many of them complained of dizziness, and that's really how I got my start into vestibular physical therapy. And since that time, I've had a wonderful career at different major medical centers doing a mix of inpatient and outpatient. And right now, I'm just a guest provider at Brooke Army Medical Center, seeing mostly outpatient neurological patients. So thank you for having me. And these views are all my own. They're not my employer's, but I'm super happy to be here and look forward to sharing some thoughts on our case.
That's fantastic. And I'd like to add that you're an excellent educator. And so it's a special privilege to have a professor be speaking with us about these topics, because I know that you have a special ability for educating others. So it's even more exciting than ever to have you.
Oh, thank you.
So we're going to be talking about a very interesting article. And that article is one that you are an author of on the list of authors. So you have a special insider knowledge, which we're looking forward to hearing more about shortly. So the article is called Treatment of Mal de Debarquement Syndrome in a Computer-Assisted Rehabilitation Environment. And this article was very recently published this year in February. And it was co-authored by several excellent other practitioners, including people are probably familiar with Sue Whitney. So, always exciting to have her on your list of authors to get her insights as well. So let's kind of review the article a little bit, and we'll talk about it along the way with Dr. Hops here. So, first of all, a definition of mal de Debarquement. We know that individuals with mal de Debarquement describe symptoms of swaying, rocking, bobbing, and that could be after sea travel, air travel, or other passive motion. And I actually had a patient, for example, who had been hanging out basically like on a dock, but it was a floating dock, so it had some sway to it. So it's not like travel the way you would think of it. But at the end of the day, the result was the same, that she had these kind of description of symptoms. And more than just having these symptoms, we do look for the patient to meet certain diagnostic criteria. We're recently updated by the Baronese Society, and the details on that are what you see here on the slide. So the full kind of consensus that we're looking for is what a patient will probably present with to be categorized as mal de Debarquement as opposed to some other condition that may have some similar features. Is we're looking for a non-spinning vertigo. Again, that rocking, bobbing, swaying is what they're usually describing, something like that. And it's usually present continuously or for most of the day. The onset is usually about 48 hours or less after the end of exposure to some sort of passive motion that they can report. So again, it might be I was hanging out on the dock. It might be I was on a train, in a plane, on a boat of some kind. These are the things that I've heard. I don't know if there's any kind of more unique passive motion that you can think of, Dr. Hops?
No, I think those are the predominant ones. Often, I think we think of this disorder following, pleasure travel on a cruise ship, but maybe individuals that are kind of new to sea travel or those long international flights have definitely been a concern for some folks. So I think you're right on
Yeah.
target.
Cool. I had someone also from a canoe.
Wow.
Yeah, I know, right? Well, and I think that we'll talk more about susceptibility in a little bit here, but yeah, it's kind of like what I'll call combo of the exposure and maybe some other predisposing factors. But yep, somebody after a canoe, which still has that rocking potential for somebody to have that exposure to that. The symptoms are often temporarily reduced with exposure to passive motion. So the kind of most common report is when I'm driving, or sometimes just riding in the car as well, I've heard. And the symptoms, again, are persistent. So they're usually more than 48 hours, and they can last for months or even years in some folks. So, kind of why is this happening? They're still trying to figure out exactly, but a pretty strong theory that's been competing for a while is a maladaptation of the stibulo-ocular reflex to roll of the head during rotation. Now, roll is not something that I kind of automatic pilot think of the way I would say my no's and yeses, which are what I give to patients for like VOR exercises. So roll is a side bend type motion is how I might characterize it. I have a nice video example. So we're going to check that out from a YouTube. So it's out in the public. I don't have to get anyone's permission here. So we have a child very excellently and cutely demonstrating. That's not a roll there. They're looking around. But eventually they go back to rolling their head again. And it's just a nice way to kind of get a sense of what a roll motion would be. So there you go. In case you're not sure what a roll is, you're not going to forget this cute baby's face. Am I right? All right.
Go.
So, we think about being on travel and how that is creating a version of that. And so what's happening when this patient persistently is feeling that sort of motion in a way? Well, back in 1962, they were researching this stuff. And they put the very brave employees, I don't know if they were actually astronauts or other types of folk, but they were put into slow rotating rooms for long periods of time where they rolled their heads at timed intervals. And afterwards, they felt terrible, and they developed an oscillating vertical nystagmus on head roll. Okay? So you kind of do this to their head, and you start to see some of this stuff. We'd say that's a central sign. And you're right. So they felt that the nystagmus induced by that head roll was indicative of a trained dysfunctional VOR. And some people get confused because they think VOR is a reflex at the ear. How could that involve the brain? But of course, the reality is, and anyone with like a central condition like MS can tell you, is they can still have a mildly impaired VOR because there are central pathways that connect to this VOR, our reflex in the inner ear, so that you cannot separate the inner ear. It's not like it's disconnected from the brain. Okay? So here it is in full. They feel that mal de Debarquement may be due to this maladaptation of the VOR. So when the person is traveling or on this passive motion, the VOR adapts to the new pattern of motion, but upon return to land, it fails to realign itself. So you get your sea legs, and then you never get off your sea legs. That's one way to think of it. Or I also think of it as like a switch, which we talked about a little bit earlier, Dr. Hops. They can't turn this perceived motion off, right? So the brain is saying that this is happening, right? Does that summarize it pretty well? Anything you want to add to that?
Yeah, I think you did a great job. It's like you said, it's this inability to readapt upon return from sea travel. So like you said, at sea, we have that mismatch of kind of the proprioceptive, visual, and vestibular information. I think oftentimes that when you're in maybe a large cruise ship, you might have stronger visual references for where the boat's vertical might be, and that may not be true with Earth vertical or where you perceive vertical to be down those long hallways with the rooms and things like that. So for sure, you return to land, and while most people spontaneously recover and that system adapts rather quickly within hours to a few days, these individuals just have this constant, like you said, bobbing or swaying or rocking sensation that's persisting due to this functional disorder.
Excellent. Nice summary. I like it. All right, so now one approach to treatment that's been around for a pretty decent amount of time at this point. I think they're definitely on over the 20-year mark of exploring this. is the roll adaptation treatment. So this is from Dr. Dye, who was based out of Mount Sinai. He's not with us anymore, but they have carried on his work. And they have proposed a treatment paradigm that involves a passive roll of the head. So passive to me means the patient's not controlling it. Passive means that it's being done to them, essentially, while watching a full field, right? So not just a little cell phone, of optokinetic stripes, resulting in an adaptation of the VOR and improvement of the Maladie-Debarquement syndrome. So is that correct? It's passive in the sense that someone else is applying the head roll, Dr. Hops?
Correct. So in the case of this individual, I had my hands on either side of their head, and I almost would kind of move my elbows kind of out to the side. And so as we would try to roll to either side, that my forearms would tap their shoulders, and it helped me to stay within that 20-degree range to either side. I've never been to Mount Sinai, but I imagine that they also had some type of examiner, because it is supposed to be a passively applied roll motion of the head. So I assume they also had someone get into this little area, and it seems rather cramped with all of their diagnostic equipment and their different monitoring devices, as you can see in their picture. But you're correct, passive motion.
Yeah, I mean, I think a machine would be too complicated, and you need some external person to make it consistent, because the patient might have trouble, getting it exactly at the right frequency, right? So,
For sure.
this is the protocol as it's been described in a published article by that group. And I pulled a lot of this kind of, so it was nicely summarized from Dr. Haynes' Dizziness and Balance website, which many people may be familiar with because it contains a pretty broad spectrum of information. So this protocol starts with looking at the severity. So you're kind of getting some measures, right? Using something called the Simulator Sickness Questionnaire, which I was not familiar with. So here it is. 16 symptoms are listed. So this is just a little clip to show you a bit of how it looks. You can see that you're scoring, based on none being 0, severe being a 3 for each of these items, adding that up, and so forth. There's math involved as usual with these questionnaires. And you can see the math there. So that's fun. And they do rate these different symptoms based off of like kind of what type of symptom I would call it, nausea versus ocular motor, or both versus like more of a dorsorientation type. And that all goes into the scoring process. So essentially we're looking at, what gets these patients going, what bothers them, and kind of what categories we would put that under. All right. Next up, you're going to measure that rocking frequency or postural sway that the patient feels in their head, so to speak. But that's what they're like, yep, this is the beat, so to speak, right? So there's a few ways to try to objectively measure that. One would be a Nintendo Wii, which they have done in some studies. Another option is an accelerometer attached to the wrist, and you have the patient move it. Yep, this is the beat that I'm feeling, okay? And then you could also use a force plate computerized posturography with, again, try to get that kind of measurement of the shift. Have I got that right, Dr. Hops?
You got it. Those are the ones they described.
Yep. So that's fun. And then you're trying to figure out if the patient has a vertical nystagmus. So this is just like what was described in the NASA work that we described a moment ago, where you're going to roll the head at the frequency that you just found. And I guess that's step 2, technically. Apologize for that mistype. But you're going to, roll the head, and then look for a vertical nystagmus. And they describe there in detail, if the slow phase is such and such, then we think, the optokinetic stim. That's those lines that we're going to put. Remember that full field optokinetic stimulus. Which direction does it need to go, right to left or left to right? So this is one way to try to discern that. Another option that some have proposed is the beloved and quite long-standing Fukuda. It has kind of fallen out of favor for kind of what I'll call a balance test, or as much of a differentiator for which side is a hypofunction and things like that. because it doesn't have that consistency necessarily that we look for in a test. But this is something that they have tried to use to discern instead of the vertical nystagmus. So essentially, you have them marching in place, eyes closed, 30 seconds. They might kind of shift to one side, rotate to a side. And if they do that on repeats, you do a few trials. And it gives an example here. If they're rotating consistently to the left, then that optokinetic nystagmus, or stimulus, would be rotated left to right. And, is there kind of a concept that because they're going left, they need to be kind of almost pulled visually to the right? Is that the link there, do you think?
I think that's possible. It's this idea that it must be off in this direction and we're going to that opposite side. So I believe that is the theory behind, this idea for sure. So in the cases we were kind of drafting the article for publication, I had the pleasure of having Dr. Sue Whitney as my committee chair for my PhD. And as we all recognize her as this international, expert in vestibular rehab. And she kept striking out Bakuda out of the paper. It was definitely one that, she knows the psychometrics. We can all appreciate the psychometrics behind the test, and that we don't advise it for clinical practice or decision making. But we had this talk and we said, this is how it was described, as you have pointed out in this original protocol. And with lack of a better diagnostic tool to help our particular individual kind of identify which direction of motion she was feeling, she definitely described this anterior to posterior, so this fore-aft swaying and this medial lateral rocking. But she was rather had an inability to really articulate which direction she may be feeling. So we had our individual actually perform this test, and again, not typically part of my practice, but to help identify which directions the stripes would go, we had her do the test as described. And in her case, it was rather remarkable that she turned 90 degrees and actually traversed, a meter, and we had to stop the test early because of just the layout of the Center for the Intrepid, where the Cairn system is located. There's this cabinet there, and I certainly didn't want her to walk into the cabinet. So we had terminated the test, reset her, and very reproducibly, she took the same exact path the second time. So with that pronounced deviation to the right, we did our stripes from right to left, hopefully to counterbalance this faulty adaptation of her VOR to rotation.
Excellent. Yeah, very interesting stuff. I'm open-minded, so maybe some tool just has a very limited but useful use, you know what I mean? So another option that had been suggested is really just trying to get the patient to identify, yep, I'm definitely feeling kind of pulled, we'll say, to the right, then we're going to run that stim right to left. So that's like a third possible, not nearly as objective, but, could work, we'll say. So another step after that, kind of determination of the direction we should run the optokinetic stimulus would be kind of running those, remember that simulator questionnaire, and just see if it's worsening rather than improving or not changing. You might just say, oh, maybe we got it wrong. Maybe the line shouldn't go this way. And then you reverse it and run them the other direction. So I call it the old trial and error method. Hey, fair enough. We all should be receptive to changing our treatment if we're not getting the response we're looking for, regardless of whether it's habituation or whatever. So here we go. This is a form of habituation. It makes sense, right? So the treatments in the study described here lasted for 3 to 5 minutes with 1 to 8 treatments per day for up to 5 days over a 1-week period, which I think you were kind of aiming for that, although you ended up not only having to do 2 days before this particular patient in your case study resolved, as I recall. So here we come and land upon the actual case study, getting into that a little bit more. The purpose of this case report was to describe an application of that treatment paradigm in a virtual reality environment with successful resolution of symptoms in 2 visits. And you can see This is from Dr. Dye's work, just kind of showing a combination of that head roll situation, the optokinetic stim, and just kind of hopefully giving everybody a full picture of what that generally looks like as a paradigm. Yep. Oh, twice. Excellent. So on to evaluation. So this is very interesting. Out the gate, we have this patient coming in referred for bilateral benign paroxysmal positional vertigo. So I'm curious as to, since it noted later on in a couple slides, I say, what your objective findings were. Were you expecting to find BPPV at all in your exam based on that, we'll say, script or what was suggested as the diagnosis?
When I have older individuals and that diagnosis comes in, I think it's much more likely. In her case, with her younger age, I wasn't necessarily expecting it, but I feel like our general practitioners have to know so much about so much that when it comes to dizziness, they do the very best that they can, but they might not be trained to the same extent that, we have taken our passion and gone down a narrow road and tried to really make ourselves, experts in the field to try to help these individuals that if you're dizzy and they don't have a reason to say that it's orthostasis or medication induced, that, well, BPPV is very common. It sounds like it could be a good option. And since she didn't express symptoms to one side or another, and this is kind of a vague description, well, it must be bilateral. And, interesting is, you go back to do your chart review, the diagnosis was assigned without a Dix-Hallpike to either side and without performance of a roll test. So I think it's sometimes they know enough to say, this is something that I know that I have a colleague that can evaluate and treat. So here's a quick diagnosis to stick on that referral, and I'm sure that this other individual can handle this and help me out. So yeah, probably not the one I would go with, but it did get her to the right spot, for which I'm grateful that we were able to help her out.
Fair enough. And a word of caution for any perhaps newer therapist, I'd say in particular, or at least new to vestibular care, and maybe you've run into this with non-vestibular work as well, but just, we get a script in front of us. It's not that we don't, attend to that information, but we obviously going to kind of do our full exam and see what's going on that day, as I like to say to my patient, because maybe there's a minute chance that she had bilateral BPV and it was already gone by the time Dr. Haps saw her. So, we just take it and then we do our exam and see what's going on that day. That's how I kind of approach it. So, past medical history otherwise for this 39-year-old female, as I recall, high blood pressure, low back pain, headaches, but denying migraines per se. Although that's always an interesting thing to kind of figure out. Is it just someone who is like, oh, they're not that bad, but they still technically would fit migraine criteria? Good question.
For sure.
Right. But I'm not saying everyone has migraine, but it's just something to think about. And then physically active, which is always a good thing, I think. So as you so well described, Dr. Hobbs, she had some side-to-side or medial-lateral, but also anterior-posterior sway. The symptoms had begun on the second day of her cruise and were persistent. And well, I guess when she was trying to be on the treadmill on the ship, she was definitely feeling off balance and felt off balance while walking on the ship. As far as your objective measures, dizziness handicap inventory, which I think many folks are probably familiar with, showed some mild dizziness, or kind of symptoms, we'll call that. And then the hospital anxiety and depression scale showed a little bit of anxiety, definitely past the cutoff of 8 that was indicated in the study, and that is supported by what literature there is on the HADS, and then on a nice lowish side for depression, I'd say. The vestibular activities avoidance instrument was medium, I think I'd call that, right? So kind of right in the middle.
I think that's fair.
Yeah, right?
Yeah, right in the middle.
Yeah, and they did also kind of do a nice 0 to 10, which we all can relate to, I think, whether it's pain or dizziness or what have you. And that was rated pretty low, I thought, at a 1. So here would be kind of your kind of description of a I think that's a 1 to 10, but close enough for, 'cause sometimes it's hard with 0 to 10s. Like, what does a 10 really mean? So they at least kind of described that in one article I found by Cha et al. In 2018, that a 10 would be like a severe rocking. I can't even walk. I got to lay down, and the 0 to me would be no rocking, and then kind of work it in from there. So just kind of giving folks some sense of how you might try to help patients who are a little unsure, what does that 10 feel like? Because some people it's just there. They have trouble kind of putting numbers to things and things like that. So patient did note a little bit of an aggravating factor, which was kind of in the parking garage. Now, was it the lighting? Was it that the moving cars? We don't really know. What was it in the parking garage? I don't know if you have any more insight on that, Dr. Hops.
Yeah, so at the campus for Brooke Army Medical Center, there's a patient and staff parking garage. It's, outside, kind of set away from the rest of the facility. And, you would think in these individuals that the passive motion of the car would be something that would alleviate symptoms. In her case, like you said, could it have been the lighting? Could it have been the visual patterns, the repeated turning, kind of scrolling and looking for a spot? I'm not quite sure. But then you probably have, a 350 to 400 meter walk to get from the parking garage to the clinic. And so somewhere thereabouts, either driving and parking or with the walk-in, that was one of the few things, as you had stated, her symptoms were mild but bothersome enough to her that she was seeking care, but definitely made worse as she was trying to get into the clinic that day.
Right. And you already described the results of the FACUDA for this individual, so we can move right along on that one. And otherwise, for the physical exam, a lot of normal testing, right? So this is kind of what some clinicians find challenging or frustrating as far as treatment planning and things like that, because it's like, oh, well, I would normally try to get their balance better. And I have had patients with Maladie Debarquement who also had balance impairments. So is it just kind of because they were pre-existing, or, because they have knee issues or whatever? There's a lot of variables when it comes into balance. Not everyone's coming in as a fit 39-year-old. So, just taking that into account. But this is the findings for this individual, at least. Lots of normal ocular motor and vestibular testing, and so forth. Definitely no BPV that day. So in comes our treatment plan. So the beloved computer-assisted rehabilitation environment, aka Karen. And I don't know a number because, of course, I did like a quick Google to see if I could just get like a ballpark. And yeah, that's one of those request your quote, which is usually like market price on the nice restaurants. So
Exactly.
I'm guessing it's in the tens of thousands. You think that's right or more?
I'm sure it's probably pretty expensive. I'm not sure. This particular model is kind of the full dome, so it's very immersive. It has embedded motion capture cameras and this treadmill that you can see in the middle. And then that platform, when the person is going to get onto the platform, it slides towards the two railings that you see so that they can step onto the platform. And then the two individuals, so the therapist and the patient, can be out on the platform together. It centers itself in the middle of the dome so that it can move in any of those different directions. So as you can see, there's a little safety harness, so they can tuck onto that harness to make sure that we don't have any falls or injuries, because you can really have the platform move very dramatically, as well as the visual surround, or in some combination of those. And this is, something that I'm very blessed in Army medicine to have access to. I recognize that it's not, in every clinic for sure. But I think these patients are often desperate for something, and there's not a lot of treatments out there to help them. Maybe it's just affirmation of their diagnosis and the symptoms and what they're feeling, almost like our individuals that have concussion, right? They're looking for that diagnosis and then that education for a likely expectation of positive recovery. That most people who go on a cruise and get off a cruise, they're fine. in your case, you have this temporary setback, but we fully expect you to recover. And it's really that, maybe that positive reinforcement, that's the most important thing of labeling this and helping them understand it with education and kind of guiding them into that spontaneous or natural recovery from it. And then I think there's that role for some individuals, maybe they do respond to some type of SSRI or SNRI, and that's an option for them. Other functional disorders respond to cognitive behavioral therapy. Is there a role for that with these individuals? I think that's a strong possibility. But in the absence of kind of solid evidence or a clinical practice guideline, what did we have available to help her? And this was really in our own backyard. So our outpatient clinic is a quarter-mile away from the Center for the Intrepid, where this is available. The second author on the paper, Michael Vernon, is the engineer operator, and he's a gifted individual at kind of coding and developing anything that you might possibly want in this environment. And we had a long-standing working relationship with other individuals that I would say, okay, I have a helicopter crew chief who flies a Black Hawk helicopter, and he gets dizzy when he looks outside the helicopter and they raise a hoist. So, hey, Michael, could you build me a Black Hawk, and could you have it take off from Afghanistan and circle some mountains with some trees? And he's like, gives you that look and takes a deep breath and lets it out. And he's like, give me a week and I'll get you a helicopter. And so he's very, very gracious with his time and talents. So when I said, could you build me black and white stripes and have them spin? He gave me the same kind of quizzical, you're crazy look, but sure, give me a couple days, give me a week, we'll put it together. And we thought, let's give it a try. And I'm very thankful that it worked, because again, there's not a lot of options for us necessarily to maybe guide our individuals in the same way that we have confidence that this is a hypofunction. I know where to go to get that CPG, and I know these are kind of the 4 hallmark things that I might want to prescribe for you. This is kind of new, and there's a lot to still be learned about MDDS.
Absolutely. And I think one of the big things that comes to my mind is I think I read that about 80% of people with maladie debarquement get better spontaneously within 3 months. But if it persists past a year, it's difficult for it to recover. And so it's one of those, could this patient that you had gotten better spontaneously? Sure, right? Because it hadn't been over a year for us to kind of say, that's not likely. But do you wait, right? That's always the question. Like, do you wait around and see, how bad does it get, so to speak, and interfere with their life in the meantime? Or do you kind of just say, hey, intervene a little bit if they get better right away, and we don't know for sure whether it was spontaneous or not, because we don't have a big group study to try to kind of do sham or anything to kind of really do more comparative studies there. And certainly that's a goal for research. But in the meantime, I don't think it's wrong, when we as therapists say, okay, well, maybe X will get better on its own, but, because it could not, maybe we do this early intervention that maybe did make a difference in that sense. And I absolutely agree with you on education, too. The patient with the doc situation, I said she was my patient, but to be honest, she was a friend of a friend, and we only ever talked. And I just kind of explained to her what maladie debarquement was. And that it could get better on its own, and to keep an eye on it, and kind of talked a little bit about what we call grounding, right? Just kind of planting, connecting, just trying to kind of get oriented to, where you're at, and do some meditation or relaxation, which is pretty much good for anyone with vestibular issues, frankly, because it just kind of reconnects them sensory wise, I think. And she did let me know, within a week it self-resolved, which is great. So, I think there would have been a line, and it probably would have been less than a year, where I think I said, we might want to touch back and see what we could do. But I think there is something to be said for patients who, if they aren't sure if their symptoms are serious, that then their anxiety or worry over that and what could it mean, or is it going to get worse and whatnot, can certainly then perpetuate some symptoms. This is a normal part of how our brain works, just like with pain. I think people are familiar with some of those pain theories. So it's not to blame the patient. It's just the way our minds tend to run. So, I think you bring up a valid point with the education as well. So it's definitely, as I like to say, many layers to the onion. So here we are, patient case treatment, which Dr. Haups performed, and she described strongly taught kneeling for 5 minutes and maintaining a very consistent head rocking or rolling, if you will. And so she used her clinical experience to choose that speed, since I think those other methods were not really adequate or available, depending how you want to look at it, to help her discern kind of what would be the proper speed, right? The frequency of this piece. And then you'd figured out already the stripe direction, so we know that part.
Mm-hmm.
So she kept that 50 beats per minute, keeping those stripes going left to right to left, excuse me, for 5 minutes. Then they got a little break. I call that brain processing time.
Yep. And probably a break for my anterior deltoids at that point, because you're tall kneeling, you're behind the patient. I try to kind of kick my arms out to the side to give myself a hard stop to either side. The metronome is going, and to let you in on a little secret, to me the motion sickness is kind of brought on by the stripes. So, I'm there behind my patient, mostly eyes closed for a better part of the time so that I'm not feeling queasy. I like to fix other people's dizziness. I think the longer I've hung out in the Karen, my motion tolerance is definitely, habituated. But yeah, for sure. I think both of us needed a break after
enough.
5 minutes of applying the treatment. So
perfect. And then she got back on and to that treadmill and was doing a simulated sidewalking activity at a reasonable speed for 10 minutes with head turns, identifying objects, which is a nice functional kind of eye and head movement activity, I'd call that. Next day, got to see her again, upped that speed a little bit on the head roll, and I believe upped the speed, yep, quite a bit, I doubled-ish. On that speed of the optokinetic stripe. So what was kind of your rationale, just out of curiosity, for doing that?
Yeah, so this was the first patient with MDDS that we had tried this paradigm on. And so I think the first was do no harm. So that we know it's in the literature that this is possible or plausible based on the work at Mount Sinai. We had never tried to put it into this virtual reality environment, and the dome is overwhelming. I don't know how many feet tall it is, but I mean, this is, a 2-story type looking big room. The building is built around the dome. So it's this overwhelming visual stimulus. And knowing her history of headaches, but not necessarily a diagnosed migraine disorder, let's start slow. Let's see how it goes. And so the 1.5 degrees per second was very, very slow. And I think I was looking at just general patient tolerance if this was going to be something that was possible with this individual. She had a mild exacerbation, but I was comfortable with that, knowing that when we retrain gaze stability, we're accepting some symptom intensity change that our patients will report, or they'll use some type of outcome measure to work a little bit into your dizziness. But we want to make sure that it settles before we do another bout, or before we advance that in some way, or even with our habituation-based other movement habituation-based therapies of, okay, you're going to take your nose to your knee, and then we're going to let that settle, and you're going to, go on to your next position. And so I was willing to accept some risk in trying this. The individual was willing. I had shown her the article. We had talked it over quite a bit in the clinic before coming down that day. And then the idea of, okay, if kind of that first day went all right, then we'll kind of ramp it up and we'll see if we can make this a robust stimulus. I didn't know exactly where to begin since we did not have an accelerometer. I had not made other arrangements to try to calculate objectively what she was feeling. I picked the 50 beats per minute because when we do our military acute concussion evaluation tool, that now brings in the VOMS, that vestibular ocular motor strain. And so that visual motion sensitivity piece we perform at 50 beats per minute. So I thought, well, I'll start with 50. If that goes okay, we'll ramp that a little bit. The 1.5 degrees per second on the stripes was very, very slow. So we doubled that, took that up quite a bit. And kind of landed there. So that's kind of how we got there, but it was definitely a lot of best guess and reliance on what we know and a little bit of experience, hopeful of a good outcome.
That's research for you right there.
It's a case study for you, if nothing else.
Very true. And then, what are your instructions to the individual? Just to look straight ahead and let the stripes go by, or?
Yeah, so that was really interesting that when we were looking at visual stimuli for my dissertation work, there's a difference in directions when you say look versus stare. So I had asked her just to look forward, not to count the stripes or attend to the stripes, but just really let the stripes go by. And with the visual stimuli, even though I was behind her, I would have expected that to generate that optokinetic nystagmus. I honestly, I don't know how you couldn't in that environment. So, we did not have a way of measuring nystagmus at the time, but that would have been a nice piece to the case study or to future research of looking at did our stimulus generate that physiologic effect that we were going for? So I guess that would have to be more to come on that.
More research needed. Yay. All right. So then we did the kind of city walk again, and this time added some perturbations of the visual surround. And this is kind of like jolting
Yeah.
Yeah.
Yep, I'd love to go about this. So we had used this same paradigm with some other individuals of various diagnoses that manifested as chronic subjective dizziness type complaints. And so this is a city scene, which city I'm not sure, but it is a busy downtown. You can control the number of vehicles that pass you on the street. You can control the number of people that are out there. You can add crowds and people can walk by. Occasionally there'll be some screeching tires or the car will gun its engine as you go by. And you can be on either the right-hand side of the street or the left-hand side of the street. So we had picked the right hand, again, thinking if this is this right deviation on the Fukuda for what it's worth, and we were going from right to left with our optokinetics, well, this would be kind of a functional way to follow up that by looking for objects down alleyways, mostly to the left side. So Michael has it programmed that there may be a yellow circle down an alleyway to the right, there's a green triangle down the other alleyway to the left, and it's forcing head turns as they scan their visual field. So they're walking and they're doing head turns. So, much like you may do some type of manual therapy and followed up with a functional movement, or manual therapy and followed up with an exercise, or maybe you do some treadmill training, body weight support treadmill training, and follow it up with overground. We had kind of taken these two paradigms and blurred them together. So again, we can't necessarily say, was it the identification of a diagnosis and education that helped her improve? Was it the dye protocol in a novel way? Was it the opportunity just to be in a specialty setting and use some of these things, or a combination of those that helped her get better, or did she just get better on her own? That's a possibility. It did cross my mind, maybe she just thought this whole thing was nuts and she didn't want to come back after 2 visits. But we did have her written permission to write up the case, and that allowed me to go back and kind of just incrementally look to see, had this individual continued to seek treatment in another clinic for the same symptoms, and she did not. So that also helped kind of reaffirm to me that within the period that we had followed up in the electronic medical record, that she had experienced a resolution, and I hope that it has lasted for her.
Awesome. All right. So just to kind of cap this case off, you guys used a global rating of change, which also was actually new to me. And I thought was a nice way to try to look at how, I always try, people say, what percent better are you from when you started and that kind of thing. But this is a nice, different way to look at it. It allows them to say, oh yeah, I'm worse, or I'm better, or I'm about the same. So she had, definitely felt, as far as this rating scale, very great deal better. That severity was down to a 0. Her DHI was a 0. She was back to her prior level of function. So, one thing you bring up in the discussion portion of this article is that this patient was diagnosed quickly. And unfortunately, the mean number of visits to receive a diagnosis of MDDS is 19. So that's pretty rough for the patient. So this quick diagnosis is unfortunately unusual, but also may have helped, again, whether that was the education piece or that early treatment piece or both, but definitely I think can contribute to a better outcome for these folks. Also, she had some tinnitus, and that was an interesting piece to me, that 89% of folks with MDDS report some tinnitus, tinnitus is often a brain kind of issue, we'll say, as well, so it does make some sense to me. So I think there's associated parts of the brain that tend to kind of complain together. That's what I'll say. And we know that migraine has been associated with MDDS. Not everyone who has MDDS has migraine. Of course, not everyone with migraine has MDDS, but there's some, kind of tie there. There's a subsection of folks that, have migraine and are maybe makes it more likely, we'll say, possibly to get MDDS if you're exposed to passive motion. I'll call it a risk factor, perhaps. And the patient did report that history of headache, but no official, kind of migraine report. And finally, there's a little bit of conversation in the article. It's very nice about kinesiophobia, so fear of movement, and fatigue, but not depression. And that was a study that was done, and that was consistent with this case report, at least. This patient did not have specific depressive reports, which does not mean that someone who has MDDS can't have either pre-existing depression or, could get depressed if their symptoms are chronic, which luckily was not this patient's case, right? She was pretty new to this diagnosis and to these symptoms, so that maybe helped. But she did report some, fear of movement, which again, to me makes sense because you're feeling like you're rocking. You're not really wanting to go to do more passive motion, I would guess. Like you kind of tied those two together. So that makes sense. So we appreciate, of course, that, this particular treatment was, in this very cool, awesome technology. So of course, not everybody has one, and not everybody has a really cool engineer who can build whatever scene you want, even if you have one of these Karen type things, technology. And the fact that not everybody, just like Dr. Hobbs, does not necessarily have a accelerometer or access to computerized posturography. So again, this kind of technology limitations, I'll call them, if someone were to, kind of try to apply this themselves. And figuring out that perceived rocking frequency can be a challenge. So the take-home message to me is that, of course, this worked. So yay for that, or at least the patient got better one way or another, we'll say. In 2 sessions. And so I wanted to bring out a few additional points to wrap up, and then we'll make some time for questions here at the end. So when I think about, me in the clinic, no Karen, no virtual reality goggles at the moment, how can I help my patient who might come in the door and I suspect they have MDDS? Because I have to say I have been the first person to suggest it to a couple people, that no one else has suggested this, and they think I'm going to fix their crystals, and that's what their problem is. But when I hear their history and they fit all the criteria and such, I'm like, not crystals probably. And then my exam usually points that same way. So one thing that we can see is that the earlier the diagnosis is made, the better. And so I think one of my jobs, and hopefully many clinicians out there could feel the same, is to really educate physicians and the community about kind of what MDDS is, not to scare people, because it is luckily that not common compared to some other vestibular conditions. But, it obviously 19 visits, it's getting pretty much not recognized by various clinicians, at least. And so, maybe just a little, hey, did you know there's this really unique condition? Not a lot of people have it, but this is what it looks like. And if you hear somebody talk about it, we can try to point them to resources. Some kind of educational talk like that might be a nice way, or a post online, however you want to educate your folks, or however you kind of reach out to physicians, and making them aware. And some, certainly for the clinicians, to be aware of the diagnostic criteria. So maybe it'll ring a bell for them. um, and note any possible associated symptoms that might not mean that they have MDDS, but just kind of that could be more common in that group. So tinnitus, headache or migraine history, and a kind of fear of movement, which could overlap with other vestibular conditions for sure, but just kind of, try to put all the pieces together, we'll say. I think the criteria are probably the biggest piece to me out of these things that we want to try to educate better. Secondly, at least the exciting possibility that virtual reality could play a bigger role in the future to increasing access. So we know the Karen was one option, but looking at headsets, certainly a more accessible, affordable option for people. There has been a pilot study that I had found that was using this Google Daydream app with some sort of particular graphics engine. And they kind of wrote in their article that you can reach out to them as a researcher. So I think as a clinician, I don't know that we have access yet to even what they're describing, but at least they're looking at it, they're studying it, and hopefully more studies will come out to give us more opportunity to say, okay, how can we realistically and hopefully effectively apply some sort of VR opportunity to present this optokinetic stim with a passive role. It makes sense that it could work, right? But clearly we don't have that research yet. You're certainly a nice seminal, groundwork case report, but we all know we need more than that to help set up kind of more defined protocols with that sort of setup and things like that. And then, when we're getting a patient through the door and it says BPPV or something, and we're doing our physical exam, this is what we might see. So we might see some symptoms on the DHI. They might have some report of anxiety or depression, or not. It's not required. They might show signs of fear of motion on this. Again, none of these are specific to MDDS, but just kind of looking for patterns is what I like to tell my students. And then, of course, looking for that history that fits the criteria is kind of, to me, the big, strong kind of factor that would make me think that direction. And then, as a bonus, we might do the Fukuda just to see. I don't normally include that in my exam, but if I was suspecting MDDS, I might be curious to see. It doesn't take that long to do. A couple of trials of that. You would not be surprised in this group to find a relatively normal exam otherwise, and that could point you to the MDDS, frankly, along with them meeting the criteria. Whereas if I find major BPV or a strong sense of a hypofunction, they could unluckily have both, but if they don't have a precipitating, factor, don't meet the criteria, now I'm going down. Well, they might feel rocking, but if otherwise it doesn't fit and they have a strong, positive head thrust test and such, then I'm going down that more like that's just the way they report their symptoms as a rocking, but it's a hypofunction, we'll say. Wouldn't be surprised to have a negative MRI of the head on this group, because maybe a doctor would have ordered that to rule out a tumor or something. And, again, it's not necessary to be true to be MDDS, but if you feel like putting infrared video goggles on somebody and you apply a head roll that's in the rhythm of their postural sway, you might get vertical nystagmus like those poor NASA folks. So, that's what you might see, just to help people as they're kind of having somebody walking in the door, with this kind of maybe dizziness diagnosis or something, and you're maybe thinking it's MDDS, just to help you out with that piece. Something that I think has come up in the literature, and I'm going to let Dr. Hopp speak to this briefly, is whether VOR exercises, so just giving them an X and having them move their head and that sort of thing. My understanding is it usually is not, by itself at least, really that helpful with these folks. So I think that's been instinctive for clinicians to try, because it's something we know, and it's like, well, it helps the inner ear, maybe it'll help readapt this kind of central VOR issue. But the answer seems to be no, that it can't just be sitting here and doing no motions. Would you say that is what you're aware of from the literature, Dr. Hops?
I would agree with you. I don't know of there really being other kind of classic vestibular physical therapy or vestibular rehab exercises that seem to alleviate their symptoms. And And I think in the absence of knowing how best to treat this or what combination might be best to treat this, we do the best we can. And so, I'll tell my students, like, if you have something that is very complicated to you, we always think first, okay, does this belong in my clinic? And if it doesn't, I need to make sure that I get it to where it needs to go. Does it belong in my clinic, but also needs some type of specialty referral at the same time? Or is this something that is appropriate for me? And if we still don't necessarily understand the diagnosis, if it's a little gray on the diagnostic criteria, I go back to my ICF model of what are those impairments, those functional limitations, those activity uh, limitations, participation restrictions. And as a physical therapist, regardless of what we call this, if you're not moving well in your environment, or you're not optimally able to do your job or your role in society, well, those are the things I can work through with you. So I might not know exactly what this is or what we call this, but I certainly have the skills and abilities to think, okay, this is weak. I know how to strengthen that. You have a challenge with balance. I know a lot about how to progress balance with you. So I think we can still reason through it in the absence of that scientific foundation. We can go back to our clinical judgment and the patient values to offset that until we know more.
Good point. Good point. So, what I did point out here is that one approach could be to be committed, because you do need to, I think, be committed to trying to stick to, what literature we do have on this role adaptation treatment. And you might be willing to set that up in your clinic, which should include seeing the patient a couple days or even 5 days in a row. So you have to kind of have the staffing, the schedule, and be willing to set up some sort of modified version, we'll call it. I mean, if they don't have a Karen, but trying to create as much field stiffness as you can. I mean, to me, it's not a disservice to the patient to try, especially if they are in Iowa and there's no way they're going to get to Mount Sinai, and then that would be paying out of pocket, as I understand, a few $1,000s for that treatment, for example, as well. So just kind of maybe trying a version of something that does have some literature behind it, even with a modified setup. And I think you should commit to trying to figure out the sway in some formal way if you can, or at least maybe trying Dr. Hops's approach of kind of her paradigm, if you will, just to see, I think the odds of you making the person feel worse are low, as long as you don't go like huge and strong. And then, hopefully it either helps or does nothing. And then you've at least tried to help. Other ideas for helping include sending them to Mount Sinai to get that official treatment that's, more kind of formalized. There is some literature that's suggesting that transcranial magnetic stimulation, which is typically used for depression treatment, could be tried. And I know there was at some point where they were trialing a home-based version of that, and that's the doctor that was doing it. So I think at least worth a reach out as clinician to clinician to say, hey, I've got a patient with malady debarquement. This physician I know has spoken extensively at various conferences on this topic, so she might be able to point you to resources that I'm not even aware of. So I just want to put her out there. I don't think she would mind. I didn't ask her, but I have a feeling she'd be okay with it. This is kind of her area. And then there has been some studies that show that treating it like a migraine, essentially, for some people seems to help. So they did do a small study where they had 15 patients, and 11 out of them, the 15, responded with improved symptoms when managed as if they had vestibular migraines. So they did lifestyle changes, and really attending to diet and sleep. They tried some migraine meds, and they had some positive outcomes. So I don't think it's my go-to, but just kind of putting that into the bucket, because at least hopefully most areas have someone that is somewhat good at treating migraine. And again, I guess worst case is some side effects from a med that doesn't help you maybe, but might be another avenue to consider just to help these patients. So we're ready for our question and answer period. So we're going to jump to that. Who's excited? Yay! Just a couple minutes to ask some questions. All right. So Learn and Move with Dr. Jen says hi. So excited for this talk. And your movement specialist is so excited to hear about this topic. Jill Zazewski says, is there any optokinetic stripe apps that a goggle system could be used with in your knowledge?
So I am not as familiar with the different goggle applications, but I have tried to use the optokinetic stripes that you could just search through, YouTube. What I do like about those is I can speed them up or slow them down. I can change their directions. So it gives me a lot of ability to manipulate those parameters. Um, Dr. Whitney in particular, and I think there are some other groups out there as well, but she actually is working with some Department of Defense funding at making a tablet-based device for VOR retraining that'll have some ability to do these optokinetic patterns. So I think we are moving in that direction. And one of the things that's so excited about that is that, this is a passive movement triggered disorder. So if I fly you to a specialty center or I fly you to Texas to try the Karen and I fix you, but then I stick you on a plane or a boat to go back home, would there be a chance that you would relapse? And I think they have shown that in some of the Mount Sinai work that they fix it temporarily and then they go back and that's a real shame. So I think that is a definite avenue of future research. So what I was hoping that we could do is do a small case series, validate that model in the Karen, and then look towards getting, funding to then pare it down and to try to get it into some type of head-mounted display. And I think that's the future of where this is going to go. And it remains to be said whether you could do it on a tablet device or not. I think there's something to be said for this full field view. So the idea of being in front of a projector and a screen or a large TV and trying to encompass that peripheral field of view, I think is important. But really, you could be low tech or high tech, whether that's striped fabric or, some other way. I would say be creative and try it because, again, like you had pointed out, there's, high reward with low risk in this to possibly intervene in a positive way.
Absolutely. So Ben T kind of tapping into that asks, would a large screen be better than using optokinetic stim than a VR headset? And I think you're kind of mentioning that peripheral. So a VR headset can have some peripheral. Is that depending on the brand, I believe? Does that seem accurate to you?
Yeah. So, again, I'm not sure specific brand to brand, but we're looking for that kind of full field optokinetic flow. And so if they have a very narrow field of view, I think we're missing out on the opportunity to really stimulate that peripheral vision and pick up some different brain pathways that we know to be involved with other disorders like visually induced dizziness or perhaps this 3PD or persistent postural perceptual dizziness that may, as we begin to understand kind of the emerging brain patterns that we're seeing in these individuals, either on MRI or CT or fMRI, I think there's something to be said for stimulating that peripheral field of view, and that we'll learn more in the next few years.
Absolutely. All right. So Benti adds, I use the Optokinetic Drum app just for those who are looking into some options. And then last but not least, Ben asks, who does the transcranial magnetic stim and who would you refer them to if you wanted that to be explored?
Yeah, so that's interesting. So I think there are many large university centers that are looking to explore that. In some of our Veterans Affairs hospitals, they are administering those. And whether or not those are mainstream or you would have to enroll in an experimental protocol, I think you need to kind of explore those options for, does your patient fit and are they appropriate for that? But I think this is an emerging area where we may see this either as a standalone treatment for a disorder, or is it some type of neuromodulation where we are priming the system to make it more amenable to rehab? Is there something to say that maybe we're warming up the brain, we're turning an area on and then we're reinforcing it with our physical therapy, or we're turning an area off and then, trying to establish a new pathway? So I think there is much to be said for this. I would refer you back to Dr. Chaw at the University of Minnesota, just an absolute brilliant clinician and researcher. This is her area of expertise. And she has looked at different types of neuromodulation, different frequencies, different, paradigms. And I think her work is still emerging, but is very promising.
Definitely, and I do understand that there is a difference between what you would do for depression, for example, as far as settings on transcranial magnetic stim, as opposed to what you would do for MDDS, as for what they've explored as far as the details on the setup of that, kind of how they apply that stim, if you will. So wrapping it up, you guys were over time because this has been so fascinating. But Craig Achitawa wanted to just add MDDS. It seems like it can start during travel, not just within the 48 hours of ending. And I believe that that is true. It can be either during travel, as in the case of your case report, or kind of within that 48 hours. I think what they're trying to emphasize with the criteria is that it's not going to start like 3 months after you rode on the cruise. It's going to be pretty much at that time or pretty soon after that you would experience these symptoms to fit the criteria.
Yeah, so I think I would now go back to that Bernet criteria to go with their diagnosis. And so, motion triggered, I think, is an important piece of this. I think it would have been a much, patients don't always do exactly what we wish them to do, and they don't read the book. But in this individual's case, it would have been a much cleaner case study had she experienced her symptoms when she returned from the cruise and they persisted for the time that she had it. She was in this evolving MDDS is where I would put her. The fact that her first presentation was on the treadmill on the cruise, I think does make it messy. And we might have a debate or a conversation at a vestibular conference one day to talk about this. But I think that is a very great point that in this particular case, her onset and the timing of that is definitely debatable. And is that fair to put this into that criteria? At the time, the Bernet criteria were not yet published, but that would have been really nice to have that guidance, because moving forward, now we can all with greater confidence say, my patient has this because they meet X, Y, and Z, versus using a cluster of things, maybe some criteria that were presented in a systematic review or a couple, seminal pieces in the literature. Now we have that good criteria to stand on. So I think your research moving forward will be much stronger for it, that we all know what we're speaking of when we talk about this MDDS. So I think I lumped her into the category where I felt she fit best. But a very good point, and thank you for bringing that up.
Very good. Well, it is always evolving, as is the research. So thank you, everyone, for joining us. Thank you especially to Dr. Hops for providing her great insights. We look forward to seeing you next month at our next Journal Club in November. You can sign up at our vestibularfirst.com/events, and the topic will be related to BPPV. So very, very much of interest to our folks. So everybody have a good night, and thanks again.